Okay, so today I'm excited to introduce our first presenter, Renee Clarke, who will be presenting on perceptions of empowerment of birthing people in the San Francisco Bay Area. Renee is a second-year DrPH student with over 10 years of experience in healthcare. She completed her MPH in maternal and child health and holds 2 bachelor degrees in nursing and health sciences. And so Renee, I'll let you take it away from here. Thank you so much for being here, and we'll leave the end for our question and answer.
Yeah, thank you so much, Karen. I really appreciate it. And thank you for everyone being here and for those who will watch this later. As Karen said, I was fortunate enough to do some research over the summertime on a data set that was done in 2020, and I'll get more into that. So as you can see, the title, Perceptions of Empowerment of Birthing People in the Bay Area. So survey methods review. Next slide. All right, and then before that, like as Karen said, I'm a second-year DrPH student. I worked in the NICU, so this is near and dear to my heart, being able to talk with moms and so forth that I previously did. So it was really rich being able to hear this data set and see what came out of it on the back end. So, all right, so what we'll go over today. So thank you. So topical background, the gaps in research, the study background, methods, findings, limitations, and recommendations, and next steps. All right, so first, before I just wanted to acknowledge some of the members of the team, other individuals that I worked with this summer. Dr. Patience Afulani, she was the PI when this research was done in 2020. And she is a researcher at UCSF. Rebecca Woofer, she is a PhD in public health student at UCLA. And then Priska Dilia, she's a medical student at UCSF as well. So I was really fortunate to be able to work with these folks over the summer. And as I go through, so Rebecca did most of the quantitative, so I will focus more on the qualitative. Next slide, please. All right. Next slide. Yes, awesome. All right, so just wanted to also start with some definitions before just some different definitions that I'll be alluding to, so we're all on the same page. So maternal mortality is the death of a woman while pregnant or within 42 days of termination of the pregnancy. And this is according to CDC. And then empowerment is the process in which people gain greater control. And here, the aspect of control is important, and the control of decision-making. And this is according to the World Health Organization. And then person-centered care, this is care that emphasizes the wants and needs of a patient over the provider. So that focus on trust, dignity, support. And this is a definition from the World Health Organization. And just also want to say that most of the individuals identified in this particular data set, they identified themselves as women. So I'll be using woman, that term, throughout the presentation. Next slide, please. All right, so just grounding us as well with some background research. So when looking at the US versus other industrialized nations, we aren't doing too good, unfortunately. So in 2020, the rate of maternal mortality jumped to 23.8 per 100,000, which was an increase from 2018, which was at 17.4 per 100,000. And as you can see, compared to other industrialized nations, there is some big gaps, right? So as you can see, France is at 8.7, Australia 4.8, going down even to New Zealand 1.7. So there is a steady increase, and that's a lot of what I would talk about today. Next slide, please. All right, so when the data is stratified, unfortunately, by race, Black women are 3 to 4 times more likely to die during pregnancy. And as you can see here, this is data from the CDC from 2018 to 2020. And so as you can see, it's increasing for everyone, but in particular, non-Hispanic Black women are the rates are the highest. So as you can see from 2018, it was 37.3, and 2020, 55.3. And this is statistically significant data. Next slide, please. All right, so I'm sure some of you all heard of the social ecological model, right? This is kind of our grounding in public health. So this is a study done by Nursi and et al. So this study went through and identified, well, what are the reasons for the disparities within Black individuals versus everyone else, right? So as you can see here, they use the social ecological model to show that it is a multifaceted issue. So for example, as you can see, like on the individual level, someone may have chronic conditions. Looking at the interpersonal level, there may be issues with provider implicit bias or differential obstetric care. Looking on the community level, there are issues with maternity deserts and issues with quality of care in Black serving hospitals. And then last but not least, on the policy or societal level, issues with Medicaid expansion, some states not expanding, and so forth. So as you can see, the issue is multifaceted, but with empowerment, we will focus, there you go, on the interpersonal level. So looking at that relationship with providers and patients. And with that being said, even though it's on the interpersonal level, there can be some recommendations for policy. Just wanted to highlight where we will be talking about today. Next slide, please. All right, so just some participation. Just wanted to ask you all, how do you feel empowered when visiting your provider? So you can answer in the chat, come off mute. What makes you feel empowered when you visit your provider? And you could throw some things in the chat. You can come off mute. Would love to hear from you all. All right, so knowledge and being listened to, that's a big one. Thank you, Annette. That's awesome. I feel empowered. Brittany says, I feel empowered when it feels like a collaboration with the care team. That's awesome. Awesome. Edgar, being able to talk with my provider that's not about health, such as overall life events. That's beautiful. Beautiful. Thank you so much for your participation. Next slide, please. All right, so some of the things that you all mentioned, right on point. So just looking at the research on empowerment. So empowerment is not a new phenomenon, right, in healthcare. So when looking at empowerment and healthcare delivery, I talked about the definition before. So the process through which people gain greater control of decisions and actions. And just wanted to talk about the actual research, some of the research that was done on empowerment. So empowerment, this is research from one of our very own, Dr. Ndula, in 2017. More specifically, empowerment is multidimensional. So some people may feel empowerment on the financial aspect, but may not feel empowered in the sexual reproductive decision-making space. Also, a study done in 2015 by Carlson et al., which talks about maternal empowerment doesn't only affect the mom, but also extends to children and families as well. And then there's another research study done in 2016 by Pratley, which says that perceived control, access to social capital, self-esteem affects a woman's ability to speak up and make decisions. So really powerful research done on empowerment. Also, there was another study, Whitewood, actually done by the International Center for Research on Women, and they created a framework that pretty much looked at different aspects of empowerment. So whether it's voice or shared decision making, and so forth, and choice. So there is a lot of research done, but there's still some gaps. Next slide, please. All right, so some of the gaps being identified. So better approaches to actually create space for patients to feel empowered. So we know that empowerment is important, but are we actually creating the space for patients to feel empowered? Also, actually using more qualitative research methods to inform how we deliver care. So actually listening to our patients, right? And using that to create models of care. That's definitely a gap. And then measuring empowerment more. So we know that empowerment is important, but are we actually measuring it, often? Next slide, please. All right. So just some background again on this study. So the original study took place in 2020, like I alluded to before. And the purpose of that in 2020 was because of the stark differences in healthcare disparities within maternal outcomes in the United States. And so that particular study in 2020 was focused on designing a scale to measure person-centered prenatal care, specifically for people of color. So that was the main objective of the study in 2020. And then the study design used CBPR, so community-based participatory research. And those approaches were used to develop the actual online survey. So interviews were done as well to inform the online survey, which was administered. And then the sample study, like I said before, was conducted in 2020, and there were 276 respondents. And this particular data set is really unique because 84% of the individuals self-identified as Black. And like I said before, it was done in San Francisco, Fresno, and Oakland. Next slide, please. All right, so just going through some of the components of the online survey. So we were able to get a lot of different responses. So the different areas focused on prenatal history, prenatal care, decision-making, social support, even discrimination. So there was a discrimination scale, and where we'll focus today is on empowerment. So next slide, please. All right, so this is just a sample of some of the questions related to empowerment. So did you feel empowered to advocate for yourself with healthcare providers? So these particular questions focused on prenatal, during labor, and then postpartum. And then they were also given the opportunity to have open-ended, so they're able to just express how they felt throughout the care and what actually made them feel empowered. Next slide, please. Okay, so in terms of methods for what I did over the summer, so it was secondary data set. So like I alluded to before, I focused more on the qualitative, open-ended responses. So I coded using deduce, and then the second coder was the medical student. So she was a second coder for us coding together. And we use grounded theory to let the data speak to us throughout and see what themes actually developed. After that, we created memos, and on the quantitative side, the individual from UCLA, we were able to use triangulation to come together and see what was the research, what was the data set saying, the different themes and so forth from the research. Next slide, please. All right, so just some sociodemographics and what we got from the sample set. So like I said, it was a sample size of 276 participants. When looking at race and ethnicity, most of the individuals were Black, 84%. Most of the individuals as well were college graduates. A large number as well were age range 30 to 45 years old. Most were married. Most either had full-time or part-time employment status, and then insurance-wise, mainly private insurance. Next slide, please. All right, so when looking at the provider type, so during the prenatal phase, most of the participants saw a family physician. During labor, this is another unique part of this sample. Most of the individuals saw a certified midwife. So this is during labor. And then when asked, so during the prenatal care, at least one provider shared the same rate. So about 78.8%, they shared the same provider as the race that they were. And then during birth, at least one provider shared the same race as well. So that was about 84%. And can you all still hear me? Okay.
Yes, we can. You
I would say
froze
my
for a
internet
second.
was unstable, but
Yeah.
okay. So provider. Oh, okay. Okay, awesome. Yeah, so thank you for that question. So yes, part of the providers was also RNs as well, but what I'm looking at here was mainly, yes, the certified midwives. Yes, that's correct, Annette. All right, so, and you're welcome. We'll ask some questions at the end as well. So, yeah, so 82% of the providers at birth were the same from the prenatal care period. So we also know the importance of continuation of care, right? So making sure you sort of like see the same provider throughout, establishing a relationship. Next slide, please. All right, so in reference to empowerment, so this is so who felt empowered? So during the prenatal period, 73.6% of individuals actually felt empowered. So overall, most of the participants did feel empowered. So that was good. And then during labor, 72.8% of the individuals felt empowered during labor. And then postpartum, 74.3% of those individuals did feel empowered all of the time. Next slide, please. All right. And then this is looking at who felt empowered, looking at categories. So about 88%, when you're looking at all the different categories, most of the individuals who felt empowered were married. Also, those individuals who felt most empowered were between the ages of 30 to 45 years old. And then in reference with educational status, college grads, they felt more empowered throughout their care. And then those who worked full-time felt more empowered throughout their care. Next slide, please. All right, so I will go more now into the qualitative findings. So this is the open-ended question. So 3 main themes came out of these open-ended questions and responses. So the 3 main areas were patient, knowledge, and support system. So these were pretty much the reasons why people felt empowered. So in addition to that, provider and staffing interactions, and then disparities in care, access, and delivery. So when looking at patient knowledge and support system, so empowerment came from lived experience. So in addition to knowledge, also lived experience. So And I will go through some of the quotes as well. So we saw a lot of individuals write about, it might have been their second birth or third birth, and they felt empowered because of those reasons, because they had already been through the process. So they felt empowered on that aspect. Other individuals felt empowered because they had or might have had some sort of healthcare experience. And then other individuals felt empowered having their partner there. So we saw the importance of having like partner support. In reference with provider and staffing, so excuse me, positive communication from providers that had people feel more empowered compared to a negative communication, right? Also continuity of care. So having that same provider from the prenatal period to postpartum, that had people feel a little bit more empowered, which went into trust and so forth. Some things that came up in the data set that was sort of more on the negative side. So a lot of individuals alluded to not having control of their care, that made them feel not empowered. So that lack of control, or feeling dismissed, or if their staff were unsupported towards them. Those are some of the reasons why individuals did not feel empowered. So in reference with disparities in care and access and delivery, some areas that individuals did not feel empowered was missed hospital service. Throughout, you would see some things as during postpartum or during prenatal, where services that should have been offered weren't offered. So that made individuals, feel not empowered. There's some issues with race concerns that were brought up, and then delaying care. So if there were issues with staffing issues and so forth, that did not make people feel empowered. And if their care was unaligned with what they thought their care should be, that did not make people feel empowered as well. Next slide. All right, so I just wanted to take some time to go over some of the quotes, because I felt as if it was really important. So when looking at patient knowledge, and these are pseudonyms, not real names attached to these. So I have a medical background, which I think helped me feel empowered. So that's in relation to what I alluded to before, with just having that experience and medical background. Another individual said, with my third pregnancy, I had the experience to know what to ask for. In reference to support system, Brianna, pseudonym, said, I felt supported by my partner, family, friends, and doula. So doula was brought up in certain instances as well. I felt prepared for my pregnancy and birth and felt comfortable advocating for myself and my preferred birth plan. Next slide, please. Thank you. All right, so in reference with provider interaction, so Devon said, during childbirth, I had an excellent nurse during labor who demonstrated respect, support, kindness, competence, and was very attentive. She listened to my preferences and ensured that I had the experience I wanted. Another individual said, so this is more of one of the negative responses. When it came to pushing, my midwife was very disrespectful and yelled at me like if I was a little girl. She told me that I couldn't scream when I was in pain. And when I was pushing wrong. I was confused and terrified because I did not want my baby to get hurt, and it didn't help that I didn't know what I was doing. So that was from Kim. And then in reference with staffing, when asked what made you feel empowered or not, understaffing. So nurses can get to the room in a timely manner. Next slide, please. All right, so in reference with disparities in care, some race concerns that were brought up, when asked what made you feel empowered or not, one individual alluded to, our race and culture are not fully accepted by all people. Someone else wrote, I want to get the same treatment as white people. In reference with delivery, I really loved being made aware of procedures and care plans. So this is what I had alluded to before, just aligning care with the expectations of the individual patient. And Ebony, another pseudo participant, I feel like my birth plan was destroyed and being pressured into induction because of my size. All right. So I just wanted to share those quotes because, reading them, looking at them, it's so powerful. And I think that we can take a lot from what patients have to offer. Next slide, please. All right. So there are some in any research, there are limitations. So with the open-ended responses, even though we had 276 participants, only 51 fully answered the open-ended response. Even though that's pretty good for qualitative, I just wanted to highlight that as well. So in reference with the sample, so the sample is based in San Francisco and certain hospitals in San Francisco. And so it may not be able to generalize to other populations and possibly a somewhat low sample size for quantitative research. And then in reference with qualitative, there was sort of limited access because it was actually just a survey, not like an interview. So I would say that's a limitation. And then in reference with the survey was about up most of 150 questions. And so fatigue could have played a role in not actually getting to the open-ended responses. Next slide, please. All right, so some things I think we can learn from what I presented on today and what we found throughout the summer. So in reference with midwives, so as I alluded to before, there was a large amount of individuals who, midwives who did actually was involved during labor. So as I said before, this was a really unique sample of 84% Black women, and overall, most individuals were empowered, it felt empowered. And so I think that really highlighted the importance of having midwives at the forefront as well, in addition to physicians. In reference to race concordance, we saw the importance of having a provider who looked like them, right? Who looked like the patient. So that was also important too. In reference with partner support, making sure that we are involving the entire family, partners within the birthing space, and promoting partner involvement in care. In reference with communication, making sure we educate and actually listen to women and birthing people, and really using that to inform care and care delivery. In reference to staffing, we all know that it's a rough time in reference with healthcare staffing, but that recommendation is more focused on hospitals having the actually appropriate staff, so patients can feel empowered, right, throughout their care, and then continuity of care as well. So having the same provider or just someone who looks like them, and in addition, the same provider from the prenatal period to postpartum. And then also establishing trust. That's important as well. So educating hospitals on the importance of trust, and focusing on trust and building trust within and among patients. Next slide, please. All right, so next steps, we're almost there. So next steps for this is focusing on creating a manuscript for this research with the team. So continuing to develop that. I also do research on Medicaid expansion. So I don't know if you remember on the social ecological model, I'll be focusing more on the Medicaid expansion. And then always willing to collaborate with like-minded individuals who, love this work. So those are next steps. Next slide, please. And last but not least, I just wanted to, this quote really stood out to me, and this was from one of the participants, and it really sort of summarized everything I felt like I talked about today. So this individual wrote when asked about empowerment, so being aware of negative outcomes for people of color, I made sure that I had my needs met. I was aware of how hospitals and doctors tend to rush births and how 1/3 of hospitals are cesareans. Friends and family have had to had emergency cesareans when I think it may have been unnecessary. One intervention leads to the next. Hearing how women in my family have been treated during birth, having their water broken without permission, feeling confined to the bed in a certain position, being told to wait or when to push. I felt like I needed to be my own advocate to make sure my birth was an empowering experience. Ultimately, hearing affirmations from the birth team, being cared for by providers I trusted, and being able to lead my own birth made me feel empowered. I just love that. So I just wanted to leave on that note. Next slide, please. Those are my references. Next slide. And questions. Thank you all for listening. Does anyone have any questions? Welcome to come off mute. We could possibly stop sharing as well.
Oh, yeah, I can stop that. Well, I just want to say thank you so much. That was a incredible presentation, and I think we all learned quite a bit. I know I did, and those were beautiful slides.
Oh.
And also thank you for this important work that you're doing. I think the more research we can do in this area, the better right now.
Yes, for sure. Thank you.
So if I can manage the chat, or if anyone just wants to come off mute, we're a pretty small size group, so feel free just to ask your question. I do have one, Renee, while we're waiting for someone else. So you said there were, what was it, 51 responses of like the total sample size of 276, and I just wondered, of that, the 51, how representative they were of the larger sample, because I was surprised with kind of the marital status, some of the other demographic one, and then thinking about that with questions around empowerment, which can be somewhat of a complicated word. Like even when you asked in the beginning, I was like, oh, how do I feel empowered? I couldn't even think of an answer right away. Thank goodness others jumped in. But so yeah, I just was wondering if you think there is any, like, people that didn't answer the qualitative, if they were different from the people that did.
Yeah, that's a really good question. So this particular sample size, when in terms of the open-ended questions, when looking at that, most of the participants actually were, it was about 50-50. So Black versus non-Black. So it was pretty representative, but I would say about 50%, 50-50.
Thank you.
You're welcome. Is the presentation going to, oh, that's a great question for Karen.
Yes, we will put it on our website. Thank you.
I thought it was you did a really nice job, and I think it was interesting because you had you had this it's kind of a best case situation. You had these married women who had midwives, had family support, educated, all these things, and they still had, they still definitely had some issues, which is when you think of what the real reality is for most other situations who don't have any of those things.
Right.
But it was interesting to see what you got. But I have a question about COVID, because when you were talking about like doulas and everything, I'm wondering how that affected the data gathering.
Yeah, that's a great question. So I know that this was, and I wasn't present for the original gathering of the data in 2020. And so in terms of, I think there were some doula involvement, because according to, well, that quote, I was surprised actually I didn't see much more responses about doulas, but I saw maybe a few responses about doulas, and in reference with COVID, I think some of the participants alluded to their partners not being there, some who were able to be there. So the study was focused on different hospitals. And so I think it differed throughout the different hospitals, depending on what their COVID protocols were like in that time.
So yeah, I was working at Sutter Health during that time, and so the doulas were the volunteer doulas were considered part of the birth team, so they could come in, but they couldn't
Okay.
bring their own private doulas, which was a problem for a lot of people. They were very upset about that, and they could always
Right.
bring their partner, but then they couldn't bring their mother or anybody else they wanted to be there.
Right.
So it was a pretty big it was a pretty big deal.
Yeah,
And then
that was
also
really
childcare was such a disaster during that time. And
exactly. No, very true. I was in the NICU at that time, and so unfortunately, a lot of moms would, you know, be in the NICU by themselves or not able to, have that support. And so, yeah, we saw that on the NICU side as well. So yeah, a lot of changes based on particular hospitals. I'm glad that in some aspect in California, doulas were able to come in if they were part of the staff. I don't think that was in other states. I don't think that happened.
no, I mean, I think having a volunteer doula program is very unusual. I don't think that's like what
Exactly.
the rest of the universe has. Yeah.
Yes. Thank you for your question.
If we have time for one more quick one, and then we're going to switch to our second presentation. See if there's anyone else. Again, Renee, I really want to thank you. And we will put this up on our website and promote it. So I know this time could have been tricky for some folks, and we want to make sure everyone has access to it.
Awesome. Thank you all so much. Have a good rest of the evening.
Okay, well,